Good evening to all those who are on Zoom and also those who are online in YouTube. Welcome you all for another lecture on colonic emergencies. And I'm happy that we are continuing this lecture series whenever the time permits. And I I would request all the participants to cooperate, and if there is anyone who wants to contribute for this lecture series, they are most welcome, and they can email me or they can WhatsApp me to my WhatsApp number, or they can email me so that we can include them in the lecture series. Those who are interested in lecture in giving some lectures, I'm happy to include them in the lecture series. And today's topic is going to be on colonic emergencies. And as the lecture is targeting the audience, those are going to appear for MRCS or FRCS exams. So the principles of uh, principles of management of colonic emergencies, which are highly recommendable by the NHS and by the as per the NICE guidelines will be discussed here. And uh, here in this lecture, it will be much more likely to be the NHS guidelines, and NHS guidelines are NICE guidelines, and the protocols which are followed in UK will be dealt here. And in general, uh, um, this is a lecture which is targeting the people, those who are appearing for MRCS and FRCS exams. Okay, coming on to the first slide. So what are the colonic emergencies? And everyone knows that those who are practicing in UK will be knowing that colonic emergencies are one of the most common surgical emergencies which we come across in the surgical emergencies. And the emergencies of the colonic emergencies can be due to obstruction of the colon. Either it can be proximal obstruction of the colon or distal obstruction of the colon, and it could be because of inflammation or infection of the colon. That could be perforation in the colon. That could be hemorrhage from the colonic mucosa, and it can be because of ischemia. So when it comes to obstruction of the colonic, when it comes to the obstruction of the colon, it can be either mechanical obstruction or it can be non-mechanical obstruction, or uh, non-mechanical obstruction. And in general, it has been said that the mortality due to colonic emergencies are high, 2 to 3 fold increase in mortality due to improper management. And uh, at any point of time, if there is a colonic emergency, if it is safe, we can convert it into an elective procedure by bridging the gap between the emergencies and electives. That if it is possible, it can be done in a safe way. Okay, so coming on to the causes of the colonic obstruction. So we'll go one by one: obstruction, hemorrhage, infection, inflammation, and one by one. So what are the causes of colonic obstruction? The colonic obstruction, most of the time in Western world, it's because of the neoplasm. And the second most common is volvulus, and third most common is diverticulitis, and the rest of the things are as follows: pseudo-obstruction, obstruction due to hernia, stricture of the colon, fecal impaction, inflammatory bowel diseases, intersusception of the colon, endometriosis of the left side of the colon or whatever, and addition due to the previous surgeries, and ischemia, probably because of either non-occlusive or occlusive arterial diseases. And next to the next slide is okay. So sorry. Okay. So when it comes to colonic obstruction, we have to be thinking about the pathophysiology. What happens in a colonic obstruction? So, for example, if there is a distal obstruction in the sigmoid or rectosigmoid junction, if there is a competent ileocecal valve, so that means the whole of the colon acts as a closed loop. So that means from the cecum, ascending colon, transverse colon, and descending colon till the obstructive site. If the ileocecal valve is competent, it becomes a closed loop. So whenever there is a closed loop obstruction, it becomes an imminent threat for the life, and there's a high chances of sepsis, and there's an increased morbidity and mortality. So any colonic obstruction we have to rule out. Is there any incompetent valve, ileocecal valve, or is the ileocecal valve is competent, because it makes much difference in the colonic obstruction. And if there is a ileocecal valve, competent ileocecal valve, if there is a closed loop obstruction in scenarios like closed loop obstruction of the colonic closed loop obstruction, pathophysiology happens in this way. So there is an increased intraluminal pressure, which causes venous occlusion of the venous occlusion of the venous occlusion, which in turn decreases the perfusion to the bowel wall. In turn, it causes arterial occlusion, leading on to thrombosis, ischemia, necrosis, and perforation of the colonic wall. So this is the pathophysiology of colonic obstruction. If the ileocecal valve is competent, if the ileocecal valve is incompetent, if there is a free flow of content between the colon and the small intestine, there's a backward entry of the intestinal colonic content into the small bowel, and it doesn't act as a closed loop. So chances of there's a decreased um, severity of the colonic obstruction. So what happens what happens, how to manage, what are the symptoms of the mild obstruction? If the in cases like, if it is so called as mild obstruction, the patient may present with cramping, abdominal pain, and constipation, but there won't be any proximal dilatation of the colon proximal to the obstruction, and surgery can be planned in an elective fashion if the disease is mild. Yeah, in scenarios like only mild abdominal cramping abdominal pain with no gross abdominal distension, or with no gross proximal dilatation of the bowel, surgery can be planned in an elective fashion. However, in cases of severe obstruction where there is a proximal bowel dilatation and pronounced abdominal distension and absolute constipation, where this is said to be an imminent threat for sepsis, and there is a systemic there can be a chances of systemic toxicity in this scenario, like tachycardia and leukocytosis. Surgery is warranted. This is in general for any colonic obstruction. So coming on to the specific causes of colonic obstruction, neoplastic obstruction comprises 20% of the colon cancer. So 20% of the patients with colon cancer present with obstruction, and of which, when the patient presents with obstruction as an emergency, as a colonic emergency, there's a 30% chance of these patients with simultaneous hepatic metastasis. So 20% colonic cancer presents to A&E with obstructive features, and 30% have simultaneous hepatic metastasis. So all these patients will be presenting with some kind of symptoms pertaining to the colonic malignancies, like change in bowel habit, weight loss, and change in stool caliber. For example, if the patient has got right-sided mass, the patient presents with obstructive features or anemia. The patient has got left-sided colonic cancer, the patient usually presents with change in stool caliber, consistency, and altered bowel habits. So in these patients with neoplastic obstruction, the patient who has colonic obstruction due to neoplasm or due to colon cancer, the initial management will be bowel rest, analgesia, resuscitation, and correction of the electrolytes, and other laboratory investigations. The role of nasogastric tube in colonic obstruction is a controversy. So everyone knows that now, if there is a ileocecal wall, competent ileocecal wall, the content of the colonic content will not enter into the small bowel will not enter into the small bowel, and there is no role for nasogastric tube provided if the ileocecal valve is competent. If the ileocecal valve is incompetent, then there is a role for nasogastric tube. The CT scan can give you a picture whether it can help you to detect. It can help you to assess whether the colonic obstruction has got ileocecal wall, competent ileocecal wall, or incompetent ileocecal wall. Sometimes the water soluble enema can be helpful to assess the level of colonic obstruction. So the role of colonic stents in neoplastic obstruction, those patients who are appearing, those who come as a colonic neoplastic obstruction, and during for that as an emergency. So the role of stems, self-expanding metallic stents. It can be used as a non-palliative stenting. That means it is used as a bridge to surgery. So, for example, the patient presents to A&E with a left-sided stricturous lesion, which causes colonic obstruction, and if there is no perforation or if there is no signs of sepsis, the patient sometimes can be stented as a bridge to surgery, making the emergency safe to become an elective procedure. So in this scenario, the bridging of the uh, situation between an emergency to elective happens because of the stenting, and this stenting helps to relieve the emergency in patients uh, those who are clinically stable, and those who are not septic can be planned for bridging can be planned for non-palliative stenting, that is otherwise called as bridge to surgery. So these can be applicable only in patients those who have partial obstruction, or for palliation in patients with inoperable disease. For example, if there is a extensive metastasis or extensive infiltration of the involvement of the adjacent organs, then there is a chance of use of stenting. And also when there is a chance for the assessment of whole colon for synchronous lesion. For example, if the patient has got polyp in the CT on the others on the proximal end, sometimes sometimes a stent can help to do a full colonoscopy, and then the patient can be subjected for surgery. And the success rate for stenting is 90%, and the complications stent migration is 12%, and obstruction or occlusion of the stent is 7%, and perforation because of stent is 4%, and it is most common with the anti monoclonal antibody called bevacizumab, which is an anti-angiogenic monoclonal antibody, which is used as a palliative measure or as a neoadjuvant chemotherapy for as a adjuvant chemotherapy for patients those who have colonic cancer. So what is the use of stent, and what happens if we use the stent and the patient? So in all these patients, when those who have been put up with the stent, the patients are subjected for surgery within 2 weeks of stent placement. And what happens? Okay, so endoluminal stents for obstruction in non-palliative circumstances have not been shown in a Cochrane systematic review to confer an additional or advantage in regards to morbidity and mortality. So that means when the patient are placed with colonic stents, so there is no advantage of patients, um, no advantage of patients in bridging the surgery, but prophylactic prophylactic colonic stent placement is not recommended, and it is reserved for patients those who are having evidence of malignant large bowel obstruction without signs of perforation. And the most important thing which I want to stress here is it is used as a bridge to elective surgery, but it is not recommended as a standard treatment of symptomatic left-sided malignant colonic obstruction. So it is not usually done provided if the patient is medically not fit, and the operation is not possible, if the surgery is not possible as an emergency, and if the patient doesn't have any features of perforation or sepsis, then the stents can be placed. So what is the disadvantage of stents? So when the stents are placed and the patients are taken for elective surgery, it has been seen that there are micro perforations around the stent placement area, and the oncological principles of resection is said to be lost when we place the colonic stents, as there is a micro perforations around the colonic stents. Okay, so the preferred treatment for palliation. So stents are definitely a preferred treatment for palliation of malignant colonic obstruction, and it is except in patients treated considered for even in patients those who have been treated with bevacizumab or anti-angiogenic drugs. In these patients, even for palliative, we have to think about placing stents because there's a chance of increased chance of perforation in these patients with stents. So what are the operative interventions? And all these things depends on the clinical condition of the patient, how rapidly we are going to deal the emergency, colonic emergencies, and the operating factors includes the tissue quality. If the patient has got soiling of the intestinal, soiling of the peritoneal cavity, we have to go ahead with the ostomy, and contamination, synchronous cancer. So, for example, if there are two malignancies, we have to think about resecting both the primaries and the proximal dilatation. So, morbidity and mortality has been shown to be equivalent between single and multi-stage procedure, and in appropriate candidates, for example, ostomy and reversal. So, some patients are given ostomy, and some patients, if the if the patient is clinically stable and if the patient has got is subjected for surgery or as an emergency, surgery as an emergency, and if there is a chance of anastomosis without any issues, the patient can go for single stage procedure, and simultaneous resection and anastomosis is advisable, even if the patient has got synchronous metastasis to liver. Okay, so which is better, laparoscopic or open procedure? So always in colonic malignancy, due to distension, colonic distension, the laparoscopic approach can be avoided. These are the reasons why the laparoscopic approaches are avoided, because of lack of visualization, and there is a chance of iatrogenic perforation of the colon, which can spill the feces into the peritoneal cavity, can cause increased morbidity post-operatively. And even in best hands, it has been said that there's an increased time of operation in laparoscopic approach when the patient has got obstructive colonic lesions because of neoplasm. So what happens? So intraoperative colonic decompression is becoming a mandatory, because for the visualization of the anatomy properly and to facilitate the handling of the large intestine. So there are three ways of intraoperative colonic decompression. One is vascular access. One is needle decompression or needle aspiration through the tinea coli, or the other one is suction, using the suction tape, again through the tinea coli. A purse string suture is placed on the tinea coli, an opening is made and the suction is inserted and suck out all the colonic content. And the third way is two-way Y-shaped suction, wherein the one end is helpful for irrigation, the other one is helpful for suction. So all these three methods are used for colonic decompression on table during an emergency, and it has been proved that on table colonic decompression helps in good viability of the good anastomotic good anastomosis rather than poor anastomosis. And regarding the management principles of management of malignant obstruction, so try to evaluate synchronous tumor on table when we do an open procedure. And if there is a liver metastasis, nothing to worry, just go and resect the primaries as much as possible and get the MDT opinion for the liver metastasis following the procedure. And liver metastasis is not an indication for ostomy at any occasion. And if possible, if it is possible to re-anastomose, it is better. If it is possible to get the continuity of the bowel, try to get the continuity of the bowel, and local invasion and the presence of peritoneal carcinomatosis has to be dealt simultaneously. Curative resection is always mandatory when possible, and metastasis does not preclude, as I said, you metastasis does not preclude resection, and re-establishment of intestinal continuity is mandatory if the patient is subjected for surgery. So where we are going to do the ostomy is a question mark. So the decompressive ostomy is indicated when there is an inoperable or unresectable disease where there's an extensive involvement of the malignancy infiltrating the around surrounding structure, and sometimes intestinal bypass procedure like ileo transfers or ileocolic anastomosis can be considered when there is a irresectable or unresectable disease when the patient is not willing for a stoma. So next comes the obstruction due to diverticular disease. So everyone knows the diverticular incidence increases as the age increases, and it's 40% at the age of 60 and 60% by the age of 80, and 20 to 25% experience a complicated form of diverticular diseases like perforation, abscess, stricture, and fistula. And the diverticular obstruction of which contributes to colonic obstruction is 10%. And always in a diverticular obstruction, a trial of conservative management is mandatory, including antibiotics, which usually resolves the obstruction. And the diverticulitis, which causing colonic obstruction, can be because of repeated infection and causing fibrosis of the particular site of the colonic wall, which causes increased fibrosis. And most of the time, the inflammation is the reason for the obstruction. So when we start the patient on conservative management with antibiotics and anti-inflammatory agents, the inflammation settles down and the lumen opens up, and thereby the diverticular obstruction gets relieved. So any patient who has got the management of diverticular obstruction during an emergency is when the patient has got partial obstruction due to diverticulitis, try to treat them conservatively and plan for an elective procedure. And if the patient, this has been studied in a single, it's a single center study where they have used stent for diverticular obstruction, and it has been proved that it has got good it has been proved that it is helpful in patients with diverticular diseases. However, in these patients, they have attempted surgery in 7 days of stem placement, and the study is not proved yet, so it is still under study. So partial obstruction, conservative, and then plan for elective resection of the diverticular segment and elective anastomosis. And stent placement is advisable, however it has not been proved. And if we place the stent, we can use it. We have to subject the patient within 7 days. So the patient can be taken up for surgery, either open or laparoscopic resection is possible, provided if there is no gross dilatation of the gross dilation of the colon. And the choice of operation and the need for ostomy depends on the situation, and depends on the perforation of the diverticulitis. Again, the decompression is recommended if there is a gross dilatation of colon, like that of neoplastic obstruction, which we saw in the previous slides. Okay, so next comes the next most common cause of the colonic obstruction is the sigmoid volvulus, and everyone knows that it has the sigmoid volvulus is most common volvulus of the colon, most common volvulus, and it encompasses 60 to 80% of all colonic volvulus, and it is usually it happens in the elderly, care home residents, or patients those who are debilitated with neurological conditions, and the patients those who are antipsychotics and those who have laxative abuse, and there is no difference in the sex. Males are equally prone for colonic sigmoid volvulus compared to female. And in the Western world, even in the younger population, we could see sigmoid volvulus, and it has been said that it is associated with Hirschsprung disease, gut malrotation, and Chagas disease caused by Trypanosoma cruzi. And worldwide, it has been said the sigmoid volvulus is more common in pregnancy, and the previous, yeah. So what happens with the pathophysiology of sigmoid volvulus most of the time, or sometimes the spontaneous detorsion occurs. And if the patient presents with abdominal pain, abdominal distension, and not able to absolute constipation, and not able to pass flap, not able to open the bowel. However, sometimes the patient can have spontaneous detorsion that can be elicited by large volume of stool and gas released when the patient gets the detorted sigmoid volvulus. In the CT scan, we can see a whirl sign in the mesentery around the vascular pedicle. You can see the whirl sign around the vascular pedicle. In the X-ray, we could see the coffee bean sign or bent tire tube or whatever. So these are the investigations usually for any colonic pathology. CT is a best investigation of choice, and CT gives you a clear picture of the any colonic pathology. So, as I said, you in any or during the emergency, we can use a rigid or flexible sigmoidoscopy to really to. It's like again like a bridge to surgery. It's like a bridge to surgery again. So we use either a flattest tube or rigid flexible sigmoidoscopy. Patients, those who are undergoing flexible sigmoidoscopy, it has to be the caution has to be taken when that the perforation or peritonitis has not happened so far. And when we do the flexible sigmoidoscopy, it is better to do with minimal air inflation when there is a suspicion of gangrene or necrosis due to volvulus. Better not to attempt flexible sigmoidoscopy. So when the patient is septic or when the patient has got gangrenous volvulus, not to attempt the sigmoidoscopy. So non-operative, the most important thing is when we use a flattest tube or when we do a flexible sigmoidoscopy in a patient who has got sigmoid valvulus, it is better to leave a flattest tube in situ or a decompression tube in situ for till we get settled down, and it has to be sucked. The decompression has to be sucked out 4 to 5 hours once, and better to take up the patient for elective resection of the valvulus rather than pixies. So non-operative management has been shown to be associated with higher mortality rate in those without prohibitive operative risk. So that means so in the patients those who have sigmoid valvulus, the patient is better subjected for resection of the valvulus segment rather than pexy, and that decreases the mortality. And coming on to the principles and principles of principal strategy in the treatment of sigmoid volvulus, as I said, you non-surgical detorsion is followed by surgical elective surgery in uncomplicated patient. If the patient has got necrosis or gangrene of the volvulus at presentation, when the patient presents with volvulus with necrosis and gangrene, take the patient for emergency surgery and do a resection, segmental resection. Primary anastomosis is done if there is no obvious spillage or there is no obvious contamination of the peritoneum. And previously we used to do sigmoidopexy or mesenteric fixation or mesosigmoidoplasty. All these things been proven to be unsafe, and there is a high chance of recurrence with increased mortality after these procedures. So any patient, it is advised to bridge the surgery. For example, if the patient is if it is able to detard the sigmoid valvulus using a flatus tube or sigmoidoscopy, and place the decompression tube for a while, and subject the patient for elective resection, segmental resection. Uh, Segmental resection. That's the best treatment. So yeah. So next comes the cecal volvulus. It constitutes 15 to 30% of the colonic volvulus, and it is more common in patients those who had prior abdominal surgery. More common in women, younger age group is also involved. Pregnancy and constipation is a trigger factor, and here in the cecal volvulus, always the rotation is clockwise. However, in sigmoid volvulus, either it can be clockwise or anti-clockwise. Usually, it is said as anti-clockwise, but it can be either clockwise or anti-clockwise. And in cecal volvulus, the ascending colon and the terminal ileum is usually taken up by the volvulus segment. And the reason behind the cecal volvulus is there is no retroperitoneal fixation of the cecum. A free hanging cecum can go for cecal volvulus. Here, the endoscopic decompression has no role. So there is no role for endoscopic decompression in cecal volvulus. However, in sigmoid volvulus, it has got a significant role. And any patient those who have cecal volvulus, the best treatment is segmental resection of the hypermobile segment, and never detard during the surgery. Don't detard the valvulus segment, which avoids the systemic toxin to enter into the circulation. And a primary ileocolic anastomosis can be done, provided again if there is no contamination. And this is a small note about cecal valvulus, which causes the colonic obstruction. So what is cecal bascule? Cecal bascule is nothing but again a form of cecal valvulus, but here in this picture you can see there is an anterior fold of cecum which gets twisted. So there is a fold, the cecum gets folded anteriorly, and it is a type of valvulus where it occurs, which is intermittent, and it causes recurrence. The most important investigation which can help to detect cecal bascule is CT, and in this patient again it is dealt in the similar way like that of cecal valvulus. So coming on to these are the causes of the till now we were dealing about the mechanical obstruction which causes colonic obstruction. Now comes the non-mechanical distension of the colon, which can present as pseudo-obstruction of, or it is otherwise called as acute colonic pseudo-obstruction or Ogilvy syndrome. Here in this scenario, the patient has got non-mechanical distension of the colon, so that means there is no obvious obstruction which could be seen in any length of the colon. However, there is a transiently absent colonic movement, is mostly associated with elderly institutionalized patient, those who underwent orthopedic surgery or gynecological surgery, or in sometimes abdominal surgeries. And these patients are these patients it is more common with again cardiac patients, and it has been said that UTI infection has a can trigger the pseudo obstruction, and there's no known cause so far which has been identified. However, they think that there is an inhibition of parasympathetic plexus causing the acute pseudo obstruction of the colon. So clinically, these patients present with abdominal distension. However, the pain doesn't seem to be correlating well with the abdominal distension, and the entire large intestine is dilated from cecum to the rectum, and we cannot find a transition point of obstruction when the patient has got when the patient presents with uh, pseudo obstruction. The management includes, so okay, when there's a chance of perforation of the cecum when there is a cecal diameter of more than 12 centimeters. So it sometimes we even say that more than 10 centimeter is an imminent threat for cecal perforation. When these patients can present with increased cecal diameter, which can be more than 10 centimeter, 12 centimeter, and these patients are managed in the same way like that of other colonic obstruction like bowel rest, resuscitation, electrolyte management, treat the precipitating illnesses like UTI, cardiac diseases. Try to stop all the medication which can cause inhibition of the colonic movements like opiates and narcotics, antidepressant, antipsychotics, calcium channel blockers, antidiarrheal agents, or anticholinergics, and try to avoid use of laxatives and enemas in patients those who have pseudo obstruction, and any patients those who do not resolve in 6 days, the chances of perforations are high in pseudo obstruction. So any patient, the patient can be observed and monitored for 6 days since the onset of symptom or since the diagnosis is made. And if the patient doesn't resolve, try to intervene with the other medications or the surgical issues. Someone is popping in the chat message. I'll answer the all chat questions at the end of the session, and anyone can contribute for the uh, discussion. So this is the picture and message I which I showed you earlier. This the line treatment of acute colonic pseudo obstruction is try to start the patient on neostigmine. It's a reusable anticholine esterase inhibitor. The side effects of neostigmine incur bradycardia, bronchospasm, hypotension, and asystole. So try to start this with the help of the intensivist. And if the patient is not responding to neostigmine, endoscopic decompression helps definitely. So if the endoscopic decompression is done, try to place a decompressive tube up to the hepatic flexure. Even in these patients, the cecal intubation can be done. The colonoscopy can move up to the cecum, and the tube should be flushed. This decompressive tube should be flushed every 4 to 6 hours and sacked out. And if the patient settles down, mostly the patient settles down with this kind of procedures, and these things are tried, but sometimes when the patients are on PAs or chronic opioid therapy, subcutaneous methyl naltrexone as an antidote for chronic opioid therapy helps in treating the pseudo obstruction. Sometimes polyethylene glycol solution is also helpful. These are the proposed management, but they don't have a strong evidence in the treatment of acute colonic pseudo obstruction with these measures. Sometimes the epidural can be used with blocking sympathetic outflow, and decompressive ostomies doesn't have any role in acute pseudo obstruction. Coming on to the next topic is inflammation and infection, which causes a colonic emergency. So the most common form of infection is toxic colitis or toxic megacolon, and we have some criteria to say. So when the patient can be subject, can when the patient can be said as having toxic megacolon. The most common causes of toxic megacolon are Crohn's, pseudomembranous colitis, or inflammatory bowel diseases causing acute colitis. So when we say acute colitis with non-obstructive segmental acute colitis, so if the diameter of the colon is more than 6 centimeter, we have to think about toxic colitis or megacolon. So what are the criteria? These are the toxic megacolon criteria. So if any three of these are the radiological evidence of colonic dilatation with these are the criteria to say toxic megacolon. The patient who has subjected for radiological investigation like CD, which shows more than 6 centimeter in transverse diameter of more than 6 centimeter in transverse colon, with any of the three features of this thing, and when these four features are there, then the patient can be said as having toxic megacolon, like fever, tachycardia, leukocytosis, anemia, which is less than 60% of the normal, and any one of the following like dehydration, altered mental status, electrolyte imbalance, and hypotension. When these things, so combine these three, any of the three criteria from this one, and any of the one criteria from here, uh, with dilatation of the transverse colon of more than 6 centimeter. This uh, these patients are said to be having toxic megacolon, and these are the list of causes for toxic megacolon. The most common thing which we encounter here is Clostridium difficile, infectious colitis, and inflammatory bowel disease. Rest of the things are rare, but we have to think uh, behind the mind for these causes as well. Okay, so when the patient presents with toxic colitis, the patient may present as a critically ill patient with fever, tachycardia, and leukocytosis with abdominal distension. If the patient is a known inflammatory bowel diseases patient, these patient can be managed with aggressive medical therapy for 5 to 7 days with steroids. And out of these patients, out of these patients, those who are managed with steroids, 20 to 40% may fail to respond with from the steroid treatment and can end up with surgery. And any patient, those who have inflammatory bowel disease and those who have this toxic megacolon, if the improvement is not attained in 24 to 72 hours, these patients are subjected for surgery. So the mortality rate is high as 20% in these patients due to colonic perforation. So always in these patients, resuscitate and correction of electrolytes helps. And serial serial X-ray abdomen can be helpful for assessment of the deterioration of these patients with IBD or toxic megacolon. So another next most important cause of toxic megacolon is the Clostridium difficile colitis, which constitutes 3% of the toxic megacolon. It has been said this specific type of Clostridium difficile has got is more prone for toxic megacolon. The virulent strain is B1 NAP1/027 strain is more specific specific to produce toxic megacolon. And these patients can be subjected for sigmoidoscopy with minimal air inflation. So why we are subjecting this patient for sigmoidoscopy is to get a sample for pseudomembranous colitis and make sure that these patients are definitely having pseudomembranous colitis without any ischemic colitis. And surgery is recommended for any patients with toxic megacolon with C. diff positive or C. diff colitis when the patient presents with peritonitis, pneumoperitoneum, and uncontrolled sepsis when there is a major hemorrhage due to Clostridium difficile. The medical management of Clostridium difficile, as everyone knows, is the vancomycin 500 milligram for 14 days every 6 hours, and metronidazole 500 milligram by mouth or intravenous every 3 hours for 14 days. And it has been said there is no difference in use of vancomycin or fidaxomicin, and it has not been proved that fidaxomicin is more efficacious than vancomycin. Sometimes vancomycin or the metronidazole can be used rectally or as in the form of enema for every 6 hours, and it can be instilled colonoscopically. The vancomycin can be instilled colonoscopically if it is possible. The best treatment, and it has been it is still under it is still been reviewed, is the fecal microbiota transplantation, either colonoscopically instilling the fecal microbiota into the colon, which has an efficacy rate of more than 90%, and the improvement is seen with this transplantation, fecal microbiota transplantation, in within 48 hours. So, surgical approach for toxic megacolon, either it can be open. The plan for surgery can be either open or laparoscopic, and the procedure is usually either total or subtotal colectomy with Brooks ileostomy. The if it is possible to do a laparoscopic assisted procedure, it is not a contraindication provided if there is no perforation or there is no gross contamination, and the reconstructive option should be deferred because as it is an infective procedure, better to avoid the uh, uh, avoid to get the continuity rather than it's better to do a ostomy or with the ostomy with a mucous fistula if it is possible. And it has been said that this it has been proved that diverting a doing a diverting loop ileostomy, sorry, doing a diverting loop ileostomy is helpful to treat a toxic C. diff colitis. And it has been said, okay, for example, if the patient has got C. diff colitis, do a diverting ileostomy and try to instill the metronidazole or vancomycin in the colon till the patient settles down, and then revert back the ileostomy. So this is under study, and this has not been proved to have more advantage over what we are doing right now for this. So the best surgical option for this toxic megacolon due to uh, C. diff or due to inflammatory bowel diseases, whatever, is best thing is do a subtotal or total colectomy with a Brooks ileostomy. If it is possible to do a laparoscopy, better to proceed with laparoscopy. Avoid reconstruction or avoid the anastomosis because as it is infective, and try to do the reconstruction at least after 3 months. So the other entity is called as neutropenic enterocolitis, that is otherwise called as typhlitis or inflammation of the cecum, which happens in most of the patients, those who have chemotherapy for chemotherapy, those who are under immunosuppressants, patients, those who have had renal transplants and aplastic anemia are more prone for neutropenic enterocolitis. And these patients present in the same way like that of the toxic colitis. They have abdominal pain, diarrhea with or without blood in the stool, and nausea, emesis, and hyperpyrexia. These patients are treated usually non-operatively and try to deal them conservatively. So other next colonic emergency is colonic perforation, and everyone know that the most common cause of colonic perforation in the Western world is the diverticulitis, and the complicated colonic diverticulitis usually 50% of the patient, 50% of the colonic diverticulitis, the complications of abscess, and 5% presence of stricture, less than 5% presence of fistula, and 1.5% present as perforation. So any patient those who have colonic diverticulitis, we know how we classify the diverticulitis into four ways: one, two, and three, four. So I'm not going to deal with this all these things. One, mild inflammation of the colon, it's a mild, it's a diverticulitis. Two, with um, pericolic inflammation, three with localized collection, four with fecal peritonitis. So any patient who has inches one and two, they are mostly managed conservatively. Three and four, purulent or fecal peritonitis, they are managed with an urgent emergency surgery. So the best treatment for it is Hartmann's procedure. Either it can be laparoscopic or it can be open procedure depending upon the uh, condition of the patient. And usually 6 to 10 liters of warm saline is used to irrigate the peritoneum, and if possible try to get the continuity of the bowel. And if there is spillage or if there is a peritoneal contamination, better to avoid the continuity and go for Hartmann's. And 30% of the patients, these patients will never have a reversal of the Hartmann's because of the either it can be because of low anal resection, or it can be because of the addition, or it can be because of the medical conditions when the patient has. So there's another study which is happening is whether there can be a laparoscopic lavage with drain placement, which can be helpful or not, and that is still under study and doesn't have a good outcome so far compared to the Hartmann's or the heart resection with anastomosis. So next is the stercoral perforation. So what is stercoral perforation? What is diverticular perforation, and difference between the stercoral perforation and the diverticular perforation? So the stercoral perforation is nothing but stercus is a hard inspissated stool which is impacted in the rectum or rectosigmoid region. So hard tools causes pressure necrosis of the bowel wall and causes a perforation of the rectum or the rectosigmoid junction. It is more commonly seen in the age after the age of 60, and male and female are equally prone, and most commonly in the debilitated elderly population. It happens in patients those who have chronic constipation, debility, megacolon, and patients those who have scleroderma, hypercalcemia, renal failure, and renal transplantation. And the most important thing is the patients those who have are on opioid and antacids with calcium blockers and antidepressants are more prone for stercoral perforation. And what are the criteria to say difference between the stercoral perforation and the diverticular perforation? For example, when we open the abdomen, when the patient, how to differentiate a patient who has stercoral perforation and who has diverticular perforation? So if the patient has a round ovoid antimesenteric perforation which is greater than 1 centimeter, and there is a feculoma which is protruding out of the colonic perforation where it has happened, and in the microscopy there should be a evidence of pressure necrosis or ulcers or chronic inflammatory reaction around the perforation site. So, and exclude other pathological causes of perforation. For example, if there is a diverticulum with, if the patient has no diverticulum with a round void colonic antimesenteric perforation which is greater than 1 centimeter with the feces protruding out of the uh, perforated site. And in the histopathology, if it says microscopic evidence of pressure necrosis, then we call them as stercoral perforation. So all these patients, those who have stercular perforation, the presenting symptoms of similar to the diverticulitis, and they have the left iliac fossa, pain, tenderness, and they present with features of peritonitis because of the perforation. And the radiological image. The most important thing here is the radiological imaging is non-specific and rarely identifies stercular perforation, and we have to the management is like that of diverticulitis. Try to resect the perforated segment of the bowel. Give a continuity if there is no gross contamination of the peritoneum. If not, do a stoma end ostomy. So colonoscopic perforation. It's not colonic perforation, it's colonoscopic perforation. 1 in 1,000 patients, those who undergo colonoscopy, can have colonic perforation. The most important reason for colonoscopic perforation is the biopsy, polypectomy, and doing a colonoscopy in a diseased bowel like inflammatory bowel disease or diverticulitis. The mechanism of colonic perforation is because of direct trauma. It can be because of the air injection causing barotrauma, especially in the ascending colon and the cecum. Most common and the procedures like biopsies and polypectomies. The most common site of perforation is sigmoid, as it is a narrowest part, and also as it has got a tortuous course of the bowel. And the as if there is if there is an ascending colon or cecal perforation, that could be because of the barotrauma. Increased injection of air into the colon can cause barotrauma to the ascending colon or the cecum. And most important thing is 50% they present with present as a present they have a delayed presentation. And again the symptoms will be abdominal pain and distension. CT can pick up the perforated site. And the most important sign is air in the diaphragm after a colonoscopy. Usually the management is conservative. Sometimes the patient, if the patients are stable, hemodynamically stable, they can be managed conservatively with bowel rest and antibiotic. As I said, any colonic pathology, think about the use of NG tube. NG tube is not going to helpful if there is a competent ileocecal valve, and if there is and if the patient has got peritonitis and deterioration with poor clinical progress, surgery is recommended, and the surgery is diversion or ostomy with resection of the perforated segment. And presently, the endoclips are used, and it gives encouraging result, which we don't have exact data on this, but it has been said that when the patient has got a colonoscopic perforation, they do a redo colonoscopy and try to endoclip the perforated site. It has been said that it has good results, but there's no evidence to say that. And large defects and peritoneal contamination, however, needs a surgery. Either it can be laparoscopic or open procedure with or without stoma, depending upon the tissue quality. So the other emergency is anastomotic leak after a post-operative colonic surgery. So it is as high as 20%, especially the anastomotic leak is very common in very low anastomosis, like low anterior resection or ultra low anterior resection. The mortality is 10 to 22%. Early leak within 1 week of surgery has very subtle signs, and especially the patient can present with tachycardia, patient not recovering from the recovering in the post-operative period, increased leukocytosis, and elevated CRP can give a sign of early leak. Can give an early leak. And the causes for anastomotic leak, either it can be operative factors or it can be patient factor. Patient factor like plenty of comorbids like COPD, anemia, malnutrition, immunocompromised, diabetic patients, patients those who had prior radiation before surgery, and any patient who has got emergency surgery who undergoes anastomosis during the emergency, or the patient factors. And the operative factors like increased blood loss and poor surgical technique, and anastomotic increased length of the surgery, and preoperative mechanical bowel preparation. It has got a controversial. I think we dealt with this mechanical bowel preparation in the previous lectures, and these are the operative factors, and there are few patient factors which can lead on to anastomotic leak. And post-operatively, if the patient, as I said you already, if the patient does not have a settled tachycardia or tachypnea, when the patient has got leukocytosis with hypotension, pyrexia, try to be suspicious of anastomotic leak. CT in patients, those who have post-operatively have high false negativity rate because of these reasons. One, the patient may have a free air up to 10 days. So free air in the CT after surgery doesn't mean there is a anastomotic leak. And there can be interloop air pockets. There is something called as loculated fluid collection next, and there's something called as localized extraluminal pockets of air. And if doesn't mean, so the like extraluminal pockets of free air can be there for 26 days, which again gives a false negativity. And the most important clinically significant CT finding for anastomotic leak is loculated fluid collection. So again, I repeat, it is loculated fluid collection, and this is a significant finding. However, any air pockets doesn't mean that there is a leak, or any free air in the diaphragm doesn't mean that the patient has got a leak. The most important significant finding is loculated fluid collection, which can be a significant finding to say that there is an anastomotic leak. If the patient has a leak after 7 to 10 days, it's very difficult to manage because of the peritoneal reactions which has already set up. And any patient those who have peritonitis or deteriorating sepsis, try to take the patient to theater immediately and do a resection and a stoma, and repair the anastomotic leak. Um, try to avoid repairing the anastomotic leak, because there is a high risk of abdominal collection and fistulation. The best option for treatment of anastomotic leak is ostomy and resection of the anastomotic segment, and try to get the continuity later on after 3 or 6 months. So the next colonic emergency is the hemorrhage, colonic hemorrhage due to hemorrhage from the colon. So 20% of the acute gastrointestinal hemorrhage are due to colonic hemorrhages. The most common reason is diverticular disease. The other common causes are neoplasm, inflammatory bowel diseases, ischemic bowel disease, angiectasis, post polypectomy, and post surgery. Usually, the hemorrhage settles down by itself. There is no need for any active management, however, and usually it stops in 24 to 48 hours. The line of management of any colonic bleeding or lower GI bleeding is medical, endoscopic, angiographic, and surgery. So these are the line of management. And medical, try to replace the blood for blood, and uh, conservative management, make sure the vitals are stable, and usually settles down in couple of days, and try to do a upper GI endoscopy and exclude any other cause of upper GI malignancy. Any other cause of upper GI bleed. And if the patients are hemodynamically stable, then give a bowel preparation and do a colonoscopy. And if the patients are hemodynamically unstable, still we can go ahead with colonoscopy. And in these patients, even in these patients, we have high cecal intubation rate without mechanical bowel preparation. So the other ways of controlling the bleed during the endoscopy is injecting epinephrine, organ coagulation, placing an endoclip, or if there is a polyp which bleeds, try to do a snap polypectomy or hot or cold snap polypectomy. After these interventions during the endoscopy, try to mark the site of bleed with the India ink tattoo, which gives a idea where the bleed happened. And this India ink, as I said you already, it will stay there for at least 1 year. And we discussed about the how the tattooing is done in the prior lectures. And the next one is next imaging modality is the radionuclide imaging, where we use technetium M99 tagged LBZ. So nowadays this investigation is superseded by the CT angiogram. The advantage of this, the advantage of using technetium M99 RBC is it can be used for 48 hours. For example, we can check if there is any rebleed within 48 hours. However, the disadvantage of this technetium M99 RBC tagging, technetium M99 is it's a time consuming procedure, and there is a high risk of false localization of around 25%, and inability to find the source of the bleeding in 25 to 60% of the patients. And next comes is the CT angiography, which has replaced almost the technetium M99 scan. And it's better. The CT angiography helps in the visualization of the vascular tree, and the site of bleed can be picked up. And the CT angiography detects bleeding as low as zero point 0.3 ml per minute. And the only contraindication for CT angio is renal failure, or the patient is allergic to the dye. And this CT angiography is continued with a selective mesenteric angiography. It becomes the selective mesenteric angiography can detect a bleed which is as low as zero point 0.5 ml per minute. So the difference between CT angio and the selective mesenteric angiography is we do a selective angiography of SMA. Usually SMA angiography is done first initially, and then IME angiography. And CT angiography, if it is followed by selective mesenteric angiography to detect the bleeding site, it has been said if it is done within 150 minutes, there's an increased, two times increased detection of the bleeding site. And if it is done less than 90 minutes, it has been proved that 8 times increased detection of the bleeding site can be picked up by the selective mesenteric angiography. So we'll see this picture. This is the picture of the SMA with the selective angiography and the super selective. So what is the use of selective angiography is when we do a selective angiography, we are going to embolize the super selective embolize the small vessels. That is called a super selective embolization of the small vessels using a microcoil gel foam or polyvinyl alcohol, and it stops the active arterial bleed in 50 to 75 patients. However, there is a rebleeding rate of 22 to 24%. See, the most important thing comes here. What is the indication for surgery when the patient has got lower GI bleed? So, if the patient has got more than 6 units of blood, there's an indication for surgery in patients who has got colonic bleed. And if the patient has got 4 units of blood in 24 hours, there is a 50% chance of this patient going for operative management. And when we infuse more than 10 units, there is a 27% chances of mortality when compared to 7% mortality when the patient has got only 10 units. So better to go for a surgical management if the patient has got more than 6 units of blood due to hemorrhage. So any patient those have ongoing bleeding in spite of these measures still goes for surgery. And when the patient is hemodynamically unstable in spite of these measures, the patient goes for surgery. So the management includes medical management, conservative, then go for CT angio, selective angiography, selective mesenteric angiography, and super selective embolization of the small blood vessels, transfusion when the patient is not settling down with ongoing bleeding. With all these things, patient goes for uh, surgery. So in surgery on table, it's better to advise, better to seek an help from the experienced endoscopist to do an on-table endoscopy to identify the location of the bleeding point and do a selective resection of the bleeding point, and which gives a less mortality. If it is not possible to localize the site of bleed, go for a total abdominal colectomy and try to rule out small intestinal bleeds before we resect the part of the colon which is going to be coming out when we do a total abdominal colectomy. If it is not possible to locate the bleeding point from the colon, try to rule out if there is any bleeding point from the small intestine or from the large intestine. So the last topic is the ischemia and colonic ischemia. The colonic ischemia can be because of non-obliterating or because of non-obstructive blood vessels, and it's called as ischemic colitis. There are plenty of reasons for ischemic colitis, like physiological hypotension, hypovolemia, hemorrhage, and the basic concept here is decreased blood supply to the mucosa or the colon causes increased chance of ischemic colitis. It can be either infective, sorry, it's not infective. It can be because of decreased blood supply to the colonic mucosa or the colon, uh, uh, intestinal wall, and there are blood vessels. There are drugs which can cause ischemic colitis, vasopressors, cocaine, diuretics, antiarrhythmic drugs, even the antihypertensives decreases the blood supply to the colonic wall, which leads on to ischemic colitis. Other causes are mentioned here. So, what are the most common causes of ischemic colitis? As I said, you it's disease, and there is an arterial embolism or thromboembolism of the arteries which supplies the colon. Sometimes there can be mesenteric vein thrombosis which causes the ischemic colitis. It's most commonly seen in the watershed areas like Griffith points or the Sudak points. In the Griffith point, where the left branch of the middle colon and the ascending branch of the left colon where it meets or where there is a watershed area of the left splenic fracture. During the splenic fracture, these two areas are more prone for Sudak point where it is a, it in the rectosigmoid region, or these two areas are the most common site can which can go for ischemic colitis. And the symptoms of ischemic colitis are abdominal pain, distension like that of any colonic pathology, definitely there will be a bleeding per rectum, and there will be an urgent desire to defecate in these patients. And a patient can present with nausea, vomiting, pyrexia, diarrhea, constipation. Sometimes the patient can go for renal failure and sepsis because of ischemic colitis. The most important thing here in ischemic colitis is the markers of ischemia like acidosis, lactate, or LDH will not be elevated in ischemic colitis. It's a clinical suspicion, and the best investigation to do to know whether the patient has got ischemic colitis is go for an endoscopy or colonoscopy. And the markers like acidosis, elevated lactate dehydrogenase are often absent in even if there is a severe form of ischemic colitis. And CT, segmental bowel wall thickening. CT can show segmental bowel wall thickening and mesocolic edema and fat standing. This is a non-specific finding which can be seen in plenty of colonic or even in colitis. The most another most important thing which is important for ischemic colitis is pneumatosis and the portal venous gas. So the portal venous gas and the pneumatosis intestinalis infers says that there's a transmural ischemia of the bowel wall, and majority of the colonic ischemia is secondary to non-occlusive diseases. 95% of these are non-occlusive diseases, and the diagnosis is best by flexible endoscopy or colonoscopy is the gold standard, which is performed with minimal air inflation, because if there is ischemic colitis, there is a chance of perforation. During this procedure, biopsies of gangrenous areas are usually avoided. So I'll show you pictures. This is a CT scan which is an extensive portal venous gas, and there's a portal venous gas here in this CT picture where this left shows the portal venous gas with a necrosis of the bowel wall. So this is the endoscopic view of the ischemic colitis, where we have a single stripe sign, and not sure about what exactly is that. And that seems to be this is the single stripe. Yeah, this is the single stripe sign, and this is the necrosis of the colonic wall, entire circumference of the necrosis of the colonic wall, which is a severe form of ischemic colitis. In these patients, the patient may need a surgery, and thumbprint sign which can be picked up in the X-ray. This is the thumbprint sign where we can. It's a clinical feature of a a radiological sign of a ischemic colitis. So ischemic colitis can be divided into three forms: mild disease, segmental. In mild disease, just treat the patient conservatively. Moderate disease, if any of the three are present, if any of the three are present, then it comes under moderate disease. Again, the moderate disease can be managed conservatively, and if any of these, if there is more than three of these things, it goes for severe form of disease. Like if the patient has got tachycardia, abdominal pain without rectal bleeding or with rectal bleeding, hypotension, male sex, blood urea nitrogen, sodium less than 136. So is all these things are blood markers of any form of procedure. So these are the endoscopic findings to say the patient has got mild, moderate, and severe ischemic colitis. As I said, your mild ischemic colitis has got mucosal edema with petechial hemorrhages and mild ulceration. Moderate ischemic colitis has got dusky appearing mucosa and hemorrhagic ulcers and submucosal hemorrhage, severe form, frank necrosis with circumferential involvement. So any patient who has got circumferential involvement of the colon because of ischemic colitis, the patient has to be uh, subjected for surgery. So as I said, you mild and moderate colonic ischemia, treat the patient conservatively. Severe form, patient goes for surgery. 80% of the patient responds to conservative management, and they avoid surgical intervention. Use of broad spectrum antibiotic, including anaerobic antibiotic against anaerobes and the uh, gram negative, are helpful in treatment of ischemic colitis. Segmental resection is recommended if there is a if the surgical intervention is done with an ileostomy. Better not to avoid primary anastomosis, like in toxic colitis. Try to avoid a primary anastomosis because we are not sure about the ends of the blood supply of the ends of the anastomotic site. So extensive or patchy involvement, try to uh, resect the bowel segment and do a laparostomy, go for a secondary look to join the bowel. Thank you all, and thanks for, and these lectures will be available in the YouTube channel, lecture series for MRCS and FRCS. And if anyone wants to know about the um, previous lectures, they can have a look. And if there is anything needed, they can comment there. I'm going to allow all to unmute themselves. If anyone wants to discuss, they can come out with the questions. They can unmute themselves now and can go for discussion if they are interested. Vivek, hi Vivek. What is the protocol for CT in case of intestinal obstruction in NHS? Is IV contrast advised? Of course, I think any patient who has got intestinal obstruction without IV contrast, I don't think they can make a. The radiologist can give a transition point. For sure, the patient needs IV contrast, and there is no role of abdominal CT without IV contrast. That's my opinion, and I think that will be the opinion of the radiologist as well, because I've discussed with plenty of the radiologists saying that without contrast they cannot make a uh, they can identify the transition point. So the question was, what is the protocol for CT in case of intestinal obstruction in the NHS? Is contrast protocol for CT in case of intestinal obstruction? I think there's no patient has to go for CT definitely if there is an intestinal obstruction. Any colonic obstruction, CT is the investigation of choice. That's what I came across with this preparation for this slide. And there's no contraindication except if the patient has got renal failure, or if the patient has is allergic to dye contrast. Otherwise, there's no contraindication for CT for any patient, those who have colonic obstruction. So that's what I came across with the preparation of these slides. So anyone who wants to go ahead for any questions, happy to do it. They can unmute themselves. They will be, they can, if you guys can, you can unmute now if you want to go ahead with some discussion.
Yeah, hi.
If there is any difference in opinion, they can come out with difference in opinion from these topics. If there is any doubts, they can ask any doubts. If there is anyone who wants to discuss the management in a different way, they can definitely.
Hello?
Let me, am I, just a minute, I'm not audible. Hello,
Hello?
hello.
Yeah, Mr. Arun?
Yes, please, sorry.
Yeah, very nice presentation. Really, congratulations to you. I would
Thank
just
you.
like to know, uh,
Yeah.
yeah, am I audible?
Yes, yes, please, go ahead.
Yeah. So I would just like to know, as far as toxic megacolitis is concerned, so do you just start them
Yeah.
on IV steroids, or in NHS is there a role of biologics or cyclosporin also before you take
No,
them for surgery?
in toxic megacolon, if the patient has got IBD or inflammatory disease presenting as toxic megacolon, then the patient has got a will be subjected for steroids, provided the patient, if the patient is having a known inflammatory bowel disease presenting as toxic megacolon. If the patient has got Clostridium difficile positive toxic megacolon, then vancomycin, metronidazole, antibiotics, that's the protocol. So if the patient has got inflammatory bowel disease, there's a role of steroids. If the patient has got toxic colitis, And the role of antibiotic in patients those who have IBD is a controversy. And steroid has got a very good role. That's what I mentioned in the slide, saying that 24 to 72 hours of steroids with IBD, with toxic megacolon, the patient responds well, then there is a role for steroid. And try to administer steroid for 5 to 6 days. 5 to 6 days, the patient settles down. And if not, then there's a role for surgery. If the patient has got toxic megacolon and inflammatory bowel disease, then steroids are advised. If the patient has got toxic megacolon with uh, uh, because of Clostridium difficile, then it is antibiotic.
I 100% agree with you. This is a textbook, this thing. But what
Yes.
recent many papers are there as far as inflammatory
Yeah.
bowel disease is concerned only. We're not talking about the
Mm-hmm.
infectious part.
Mm-hmm.
So, if inflammatory bowel
Mm-hmm.
disease, most of the times, the patients who turn into
Mm-hmm.
toxic megacolon, they usually have had an steroid trial already. So, in such cases, most of
Mm-hmm.
them are steroid resistant. You know? So
Mm-hmm.
they what they have seen is biologics. I'm not talking about antibiotics. So role of
Yeah.
infliximab and adalimumab as a
Okay. So
as an alternative to emergency surgery in cases who are resistant to steroids. Steroid, yes, the first line of treatment will be steroids in medical management. But if steroids
yes.
fail,
So any
so can we go for a trial of biologics, or cyclosporin as such also has been tried in many trials?
from the textbook and from the guidelines which I saw, I don't think we use any immunomodulators or any monoclonal antibodies for inflammatory bowel diseases in acute emergencies.
Okay.
So the only thing which are supposed to use is and steroids. And I have not come across use of immuno immunoglobulins. I think if I'm not wrong, it's anti monoclonal antibodies in the emergency
Antimonoclonal, yeah, yeah.
during
But
the
I
emergency.
have come across there are papers.
Hmm.
So maybe yes, it's not in the guidelines,
That's
but yes,
what
I
I
have. Yeah,
actually, yeah, what I wanted to hear stress here is here we are dealing with any patient like
exam point.
with which are controversial is it's a big thing. We can discuss
Yeah,
the controversies in different ways, but
yeah, yeah,
here
yeah, definitely.
we are dealing with the things which have a definitive role. That's it.
Exactly, exactly. I appreciate that.
Thank you. Thanks for
Thank you.
discussion. Yeah.
Thank you.
Prem and infliximab has a role. Yes, I think it's has a role if there is an inflammatory bowel disease which is flaring up, but I don't see any role of infliximab in toxic colon. I could see only the role of steroids, and that too especially for 24 to 72 hours, and I don't have any other role of monoclonal antibodies in inflammatory bowel diseases causing toxic megacolon. And if there is anyone who wants to discuss or give any discussion or points to add up, um, they can either give it in the chat box or they can unmute themselves and can come out with the questions and answers. So if there is no question, let me wind up this session. Thank you all for attending the session, and this will be available in YouTube as usual after some time. And I'll inform the next lecture and the topic in the social media. Thanks for attending. Thank you all for joining me. Thank you.
Thank you.